your timer, and here is your question. Right, so if you have read and understood, considering it clinical examination station, kindly begin.
My name is Nurana Abdelmomen. I'm one of the exam candidates. Can I
Yes.
confirm your name and age, please?
Yes, I'm Smith, 37 years old.
Okay, Mr. Smith. I'm gonna do some knee examination, and that would involve looking and feeling.
Yes.
Is that okay with you?
Yes,
Okay. Do you have any pain in your knee?
yes, I do.
Okay, I'll try to be as gentle as possible with my examination.
Okay,
Firstly, I would look for signs of inflammation, swelling, any obvious deformities.
yes,
Then I'd ask the patient to, if you'd walk around for me, please, so I can check your walk.
okay, doctor, it hurts, I can't walk.
The left knee hurts.
Yes,
Okay. Then I would ask the patient to lie down to feel the left knee, but since it's painful, I would try to. I'm not really sure how to complete the examination with the pain. Because I would like to do some tests like anterior jaw and posterior jaw.
begin with palpation, right? After,
Yes.
yeah.
I would compare the temperature between both knees to see
Yes.
if there's
Yes.
active inflammation.
Yes,
Since there's some inflammation and swelling, I would assume it's hotter than the other one. There's probably redness. I'd see if
okay.
there's redness.
And
I would also try to see if there's effusion, joint effusion.
Yes,
So I'd
yes.
bring both my hands from below the knee and from above the knee,
Yes,
and as if I'm milking the effusion into the knee joint.
okay,
And then I'd palpate if there's effusion with both indexes.
okay,
Also, that's for palpation. Also, I'd see the back of the knee. I'd palpate the back of the knee if there's
Yes.
Baker's cyst or so.
or
Uh,
any other popliteal fossa mass, and you will feel for the popliteal pulse.
Yes.
Yes,
Then I should do the tests.
quadriceps circumference.
Oh yes,
Yes.
I forgot.
And then, yes,
Can compare both sides.
yes, and then you'll do the movements.
And then I'll do the movements.
Yes.
I'd ask
First,
the patient.
yes, because it's
I'd ask,
active pain, so you'll ask for the active movements first.
okay, so I'd ask the patient to flex and extend his knee.
Yes,
And then I would attempt to do it and then stop. If the patient exhibits any sign of pain, I'd make some eye contact to see if there's a sign of pain while I'm moving his knee.
okay, yes. What
Uh,
special test would you do?
Special tests.
Yes.
First, I'd ask permission to sit on the patient's foot to do the
Okay.
anterior and posterior jaw tests.
Okay,
The anterior jaw, I would sit on the patient's foot and he'd flex his knee around 90 degrees.
Yes.
And then I would briskly pull his leg towards me. If there's exaggerated anterior movement, that would mean an anterior cruciate ligament injury.
Yes.
The posterior draw test is the opposite, so I'd push the leg towards the bed. And if there's exaggerated movement, it means that there's posterior cruciate ligament injury.
Yes.
And then there are the medial and the lateral ligaments.
Okay. Which test would you do
Longitudinal
to
ligaments.
rule them out? Yes.
While the knee is extended, I would put my left. Okay, so this is the left knee. I would put my left hand on the medial side of the knee, and then if I take the leg medially,
Yes.
then it would mean that the lateral longitudinal ligament, if there's exaggerated movement, it would mean that the lateral longitudinal ligament is injured. And then I would do the opposite. I would put my left hand at the lateral aspect of the knee, and then push his leg outwards in a valgus movement. So if there's exaggerated valgus movement, then that would mean that the medial longitudinal ligament is injured.
Yes.
So those are the movements of the knee. Also, I forgot to mention that in palpation, I should feel for the joint line. I should feel for the tibial tuberosity.
Good.
And then follow with the patellar tendon and the patella.
Yes. How do you do patellar tap test to rule out fusion?
Okay. Patellar tap. I remember we should, from my college days, we should move the patella above and downwards. Yes. I think. Yes. To see if there's if it's hypermobile, then it means that the tendon is ruptured.
Okay. Can you, Bell has gone. Can you summarize your examination now, please?
Okay. Today I examined a 30-year-old gentleman who complained from a knee trauma 2 days ago. On examination, by inspection, I could see that the left knee was inflamed and swollen. Yes. On palpation, it seemed to be hotter than the other side. Also, there was some effusion. Yes. At the knee joint. Through the examination and with some special tests. For example, this patient, I would expect it's a twisting injury. Okay.
So which test was positive?
I would expect it to be the medial cruciate, the medial longitudinal ligament. Okay.
Then which test would be positive if that ligament is injured?
The positive test would be the varus. It would have a hypervarus mobility.
Okay. Right. So what is your differential diagnosis?
My differential diagnosis would be medial longitudinal ligament injury.
Okay. Sports injury. Yes. What are the investigations that you'll ask for to confirm your diagnosis?
Firstly, we would need to do an X-ray to exclude the fracture. Yes. But then an MRI would be necessary for the soft tissue and the ligaments. Then the patient could consult with an orthopedic surgeon for repair or conservative management.
Okay. What should be the first line of management for this patient?
The first line would be, I think it would be repair of the ligament, surgical repair of the ligament. If the ligament is not injured, then conservative treatment with with heat pads and rest and
Okay.
analgesia.
Patient, patient is an athlete. When do you consider patient would be fit to practice or fit to play soccer or football again?
I think it's debilitating. I don't think
yeah, how long?
so. After complete resolution of the injury,
Yes.
9 months, I think, or something.
19 because patient will be rehabilitated as well afterwards. Good, thank you.
Thank you.
Started your timer, and here is your question. Right, so if you have read and understood, considering the clinical examination session, kindly begin.
I will enter the room, wash my hands, the patient. Hello, how are you today?
Yes, I'm good.
I'm Dr. Muhammad as a surgical doctor. They have been asked to examine your knee. Okay, this will include looking, feeling, and also watching you walk and do some movement. Are you okay with that?
Yes.
Thank you. May I confirm your name and age, please?
I'm Philip, 28 years old.
Okay, nice to meet you, Philip. Do you have any pain before start?
Yes. But
okay.
Yes.
Okay. Do you need any analgesic?
No,
right
that's
now?
all right.
Okay, can you stand up for me and take off your gown, please?
Okay.
Thank you. Can you just take a few steps for me, please?
All right.
Okay.
You have to tell the direction, in which direction to face.
Just towards the wall.
Yes, good.
Okay, perfect. Now I would like to just have a inspection at your knee, okay? Looking for any quadriceps muscle wasting, looking for any surgical scar, any deformity, any abnormal alignment. Now can you turn to your right, please? I'll expect the same, and can you turn again? 360 degrees. I would expect for knee flexions and popliteal swelling and any surgical scars as well, and foot arch as well. Now can you lie down, couch for me, please?
Okay.
Good. Now I'm going to have another local inspections at the post knee for the same. And okay, now I'm going to feel you. If you felt any pain, please let me know. I will stop. Okay.
Yes.
First, I will assess temperature at 3 levels at the thigh and at the knee and the leg. Now I'm going to feel at your knee. We'll start from the quadriceps tendon downward over the patella and the patellar tendon. Then on each side of the patella and also the medial and the lateral knee lines. Now I'm going to just do the sweep test and the belt test. I'm going to sweep from with my left hand, sweep thigh downward, and
Yes.
with my right hand, using the middle finger, just palpate for the patella and look for any effusion. Just looking for the large effusion. Okay, now I'm going to this patellar tap test. Now I'm going to the sweep test. Just going to sweep with my left, with my right hand and upwards, and with my left hand downward, looking for any small effusion. Okay.
Yes.
Now, can you just flex your knee, please?
Okay.
Okay, now I'm going to feel at your knee again for the tibial tuberosity and for the medial and the lateral knee alignment. And for also, I would like to feel for the popliteal pulse and any popliteal swelling or any abnormality. Okay. Now, I would like to test your movement, Mr. Phillips. Okay. Can you
Okay.
just flex your knee as much as you can?
Yes.
Okay. Now, can you extend your knee again?
Okay.
Okay, fantastic. And do this for the other leg.
Yes.
Okay, brilliant. Now I'm going to do some test. Okay, I'll start by the draw anterior posterior draw test. Can you just flex your knee? I will just move it anteriorly and posteriorly, looking for any anterior and posterior cruciate ligament abnormality. Now I'm going to do the valgus and the varus test. I will elevate your knee. Do you have any pain at your hip joint?
No. It's
Okay.
just at the knee joint.
It's okay. Now I'm going to just put my right hand over the calf and do some pressure from the medial sides, laterally, testing the lateral ligament. This is the varus test, and the opposite side for the valgus test. Now I'm going to do the McMurray test. McMurray test, I will just do the internal and external rotation of the knee. Internal rotation, this means I testing the medial meniscus, and the lateral rotation, this testing the lateral meniscus. Okay. Now I'm going to the Lachman test. I will just do some pressure at your thigh and at your leg. Okay.
Okay.
Testing the anterior lateral ligament, looking for any pop sign or any pop sound. If you felt any pain, please let me know. Okay.
Okay.
Now I'm going to lift your knee at just 10 degree, looking for passive knee extension. And now I'm going to posterior sac sign. Just going to flex your knee on 90 degree. Okay. Looking for any sagging of the leg. Now I have completed my examinations, Mr. Phillips. Thank you so much for your time. I will.
Okay. Can you summarize your examination now, please?
They have examined Mr. Phillips, 52 years old, who presented with pain in the left knee joint. On assessing gait, was having an antalgic gait. There is no any surgical scars, no deformity, nor any swelling in the knee joint. On palpation, patients having temperatures normally and no any muscle wasting. And on the assessed, there's decrease the active and passive range of movement in the left knee. And on assessing the all the special tests, McMurray test and the valgus and the varus and the Lachman test or tests were normal. So my main differential diagnosis is left knee osteoarthritis. Also, I have to consider gouty
Post-traumatic, left knee post-traumatic osteoarthritis. Okay. What investigations would you ask for to confirm your diagnosis?
First, I'll go for blood test, CBC, electrolyte, ESR, and inflammatory markers, C-reactive protein, and uric acid. And also then I'll go for imaging like X-ray, weight-bearing X-ray, anterior, posterior, and lateral view. And then I will also do the MRI, the left knee.
All right. What are the management options that you can offer to the patient?
First, conservative treatment.
Yes.
I will encourage the patient to go for exercises and reduce weight if it's obvious. And the start is analgesia and steroid anti-inflammatory drugs.
Yes.
And also encourage the patient to go for cycling just to string the muscle around the knee.
Yes.
Then I will go for intraarticular steroid injection If it's failure of
Yes.
treatment, then I will go for surgical options, arthroscopy, realigned osteotomy, partial or knee, total knee
replacement. Okay. Once you do the X-ray of the knee, what are the signs that you should look out for?
I will look for any cyst formation or any sub osteophyte formation of chondrosclerosis or
Yes.
increase or narrowing the joint space.
Narrowing of the joint spaces. Yes. Okay, good. Right. Right, good. Thank you.
Thank you.
Okay, started your timer and here is the question.
Ma'am, can you please share in a big screen?
Make it bigger.
Okay, sure, thank you.
I don't know, how can I? Is it too small? Are you
No, no, ma'am, it's
bringing
okay.
it
It has been
on
done.
iPhone? You can
Yes.
just pinch it and make it bigger.
Yes, ma'am, it has been bigger now on the main screen.
Okay. If you have read and understood, considering this communication skill station, kindly begin.
Sure, ma'am. Hello, good evening.
Good evening.
I am Dr. Mohammed Zulkarnain, one of the surgical resident ST3 in THK hospital. I'm working under Dr. Man. I am the vascular surgeon. I am going to talk to Dr. Man. May I confirm it is if it is Dr. Man, the vascular
Yes,
surgeon?
I'm Dr. Man.
Okay,
So,
thank you. Doctor, I have to discuss with you with some patient who has been admitted to our ward. Should I summarize?
Yes, summarize your case.
Okay. Here is a 54-year lady who was admitted in our ward with the preemptive diagnosis of diverticulitis. And we started resuscitation, and the patient is improving with antibiotics and fluid. But now the patient is complaining of acute severe pain in the left lower limb. We have examined the patient, and distal pulses an examination. Distal pulses are absent. ECG has been done. It shows the pattern of atrial fibrillation along with the broad preventricular complex, and ABGs have also been completed, and this shows metabolic acidosis along with hypokalemia. So accordingly, arterial duplex scan was requested, which confirms acute limb ischemia of the left lower limb. So I have to discuss with you about this patient.
okay. What are you want to do for this patient right now?
I just want to shift this patient under your consideration for the treatment and management of acute limb ischemia.
Is it urgent? Can you send this patient tomorrow instead?
Sorry, sir, but as we are suspecting, and also a clear duplex confirms that is acute limb ischemia, so we cannot wait, and the patient has to be shifted as early as possible.
Okay. You just mentioned that patients having atrial fibrillation of preventricular complex. You would like to just call the cardiologist to review this before you transfer the patient?
Sorry, I couldn't understand your question.
Do you need a cardiologist to review this patient before the transfer?
Okay, we have I will talk to IT registrar, and also he will arrange some necessary equipment and some necessary management for this patient during this shifting of the patient. But we have to shift this patient under your consideration regarding limb ischemia.
And what do you think of Arboretum diagnosis of diverticulitis? Could it be something else?
Sorry, your
What
voice
do
missing.
you think of the presumed diagnosis of diverticulitis of this patient?
Oh, okay. So diverticulitis, the patient was having abdominal pain, and also ultrasound was done, and some investigations which shows that the patient has diverticulitis. But now the patient is showing improvement along with antibiotics and by the antibiotics and fluid management. So considering this, we can manage this diverticulitis later on, because if the patient acute limb ischemia becomes severe, we are feared to lose the limb.
Okay. Do you want to just scan the abdomen first before you transfer?
Do you want?
To scan the abdomen first before you transfer the patient?
Patient can be scanned after the shifting to the under your hospital and under your consultation. Can be done there.
Okay. Could it be mesenteric ischemia?
Yeah, considering that the patient is having atrial fibrillation along with the preventricular complex, and having ischemia, having a lower limb ischemia, it can be mesenteric ischemia. But as now the patient is improving, we can go for further investigation once the acute limb ischemia has been managed.
Okay. Okay. How would like to manage this patient?
How much?
How would you like to manage
How you
the
would like?
Yes, because the patient is having acute limb ischemia, so we have options according to the limb condition. If the patient has salvageable limb, then we can go for embolectomy, thrombolysis, and later on anticoagulation. But if the patient and even we can go for bypass graft, and but if the limb is not salvageable and
Hello.
I think you got disconnected.
Hello.
We can't hear you. He's talking, but we can't hear you.
hello.
Yes, now.
Yeah. Hello.
Yes.
Okay. How would like to manage atrial fibrillation?
Yes, atrial fibrillation can be for to manage the atrial fibrillation, we need anticoagulation along with the cardioversion. Cardioversion can be done pharmaceutically and also by the mechanical way. So we have to inform the ITU registrar, and we can manage it accordingly.
Okay. What type of ambulance you will need for this patient for the transfer?
For this patient, we need the ambulance which is equipped with the oxygen along with the
Mention the
cardioversion.
name of the ambulance. Okay.
It will be sorry, ma'am, I don't know the name of the ambulance.
Okay. Which
But
type
it
of
will be equipped with
antibiotic?
the cardioversion, with the CPR facilities, and all the facilities for cardiac for cardiac resuscitation.
Or blue light ambulance.
Blue light.
Yes.
Okay.
Okay. What anticoagulants could you give to the patient?
We will give heparin to this patient, 1 cc or 5,000 international units intravenous bolus, and then 15 international unit per kilogram per day.
What would you inform to the family of the patient?
We inform to the family of the patient that blood circulation to the lower to the leg has been stopped due to some clot in the vessel, and that is why, to save the limb of the patient, we have to, and also to treat it, we have to transfer the patient to the some vascular surgeon, some surgeon who is dealing with the vessels of the limb.
Did you tell the management of metabolic acidosis and hypokalemia? How would you
Yes.
take care of hypokalemia?
For hypokalemia, we have to consider the values of the potassium in the blood.
Yes, you have disappeared.
If it is less than 3 millimole per liter, then we will give 10 millimole of 10 milliequivalent of potassium every hourly, IV slowly for 5 hours, and then we will recheck the potassium levels. But if it is more than potassium every hourly for 3 hours, and then we will recheck the levels.
Okay, good. You can send over the patient. Thank you. Started your timer, and here is your question. You'll get 1 minute to read the question. Right, so if you have read and understood, considering that history-taking station, kindly begin.
Hello, my name is Dr. Saad, one of surgical doctors looking after you. Can I confirm your name and age, please?
I am Smith. I am 44 years old.
Okay.
Okay, Mr. Smith, today I have been asked to ask you some question about regarding your complaint. Is it okay with you?
Yes.
Okay, then what brought here today?
I have a difficulty in swallowing, doctor. I just can't eat anything these days.
Oh, I am sorry to hear about this, Mr. Smith. Do you have the difficulty swallowing solid food or liquid food also?
I actually started with the solids, let's turn now to the liquid as well.
Oh, and when was the first time you noticed this difficulty?
Started like 6 months ago.
And it's getting worse with time, or it's same?
Worse, doctor. Even liquids. I have difficulty swallowing liquid.
You have any vomiting, Mr. Smith?
Yeah, I have vomiting that twice.
Do you feel any pain while swallowing?
Just I feel like I have a mild discomfort when I'm swallowing.
So you don't feel any pain?
I feel pain, but it's mild, maybe.
Oh, sorry to hear this. Is there any food stuck in your back or throat?
No,
Do you feel any like sound or gargling sound while swallowing?
no, no.
Okay. You have any like abdominal pain or constipation, loose motions?
No,
You have any like chest pain or abdominal pain or chest pain?
no,
What about your bowel movement? You have any like less motion than usual, constipation?
no, no.
Okay, Mr. Smith. Do you feel any weakness in your legs?
No,
You suffered before from like red and painful eyes?
no.
Okay. So can I ask you some personal questions?
Yes, please.
Do you live alone or you live with someone?
I live with my family, wife, children.
Are you smoking?
Yeah, I smoke a lot, like 4 packs per day.
4 bags per day. For how many years now?
Like 17 years.
Okay. Do you drink any alcohol?
Yeah, I drink a lot actually, like 5 units per day.
How many units per day?
5 units.
5 units.
Yeah,
Okay, Mr. Smith. Do you have any difficulty with climb with stairs?
no,
So regarding your you like have any visited your GP for any other medical conditions?
yeah, I'm hypertensive. I visit my GP for regular follow-up.
For
Regular follow-up.
regular follow-up.
Yes.
Okay. So you're not taking any medicine, Mr. Smith.
I'm taking for this hypertension. I'm taking for amlodipine 10 milligram.
And your blood pressure last time checked it was controlled?
Yes.
Okay, that's good. Then, Mr. Smith, you did any surgery?
No.
No. In your family, first 3 relatives, like your father and brothers, do you have any medical conditions?
No, no.
Okay. Have you lost any weight recently?
Yes, actually, I have lost like 200 pounds over the last 6 months.
Last 6 months. Oh, sorry to hear about this. What about you have any bone pain or joint pain?
No,
Any cough or wheezy?
no, no.
How about your sleep?
Sleep regular, no sleep disturbances.
Yes, well, Lesbon, can you please summarize your history now?
I have Mr. Smith, 54 years old. He complaining of long-lasting 6 months history of progressive dysphagia. Started with solid and now with liquid.
Yes.
There is loss of weight, no other constitutional symptoms. My first diagnosis would be esophageal carcinoma.
Yes.
And
What other differential diagnosis you will consider?
I will consider, ma'am, I will consider achalasia of cardia, gastroesophageal reflux disease. I will consider also esophagitis and
What
autoimmune disease like.
Yes. All right. Okay. What investigations would you ask for to confirm your diagnosis?
As the most concerns cancers, and we will start by doing OGD with biopsy if there is mass.
Okay.
Then we'll go for lab investigation, full blood count, urea rate, and liver function tests. We also need to do
Esophageal manometry because you asked for eclasia or GERD. Barium swallow.
yeah,
Yeah.
barium swallow follow through. We can do also for staging like CT scan for chest to look for metastasis.
Good. Okay. What are the treatment options that you can offer to this patient?
Regarding dose staging and grade of the cancer, whether there is operable or non-operable cases. Operable will do esophageectomy with chemo and radiotherapy. If
Yes.
non-operable, will do palliation chemotherapy and stent, metallic stent or silk or plastic stent.
Okay. Good. Thank you.
Thank you.
Right. One little feedback.
I think I had a lot